from the first week. I know typically when things kind of go not as expected, it's very hard to kind of get your week started correctly. So I think we have all of that fixed now, for sure. And we hopefully should not have any more hiccups since all the assignments either come from um, FA Davis or it's the prep assignments that are already made and put on there. So I did look over your exams from last week. It was overall okay. OB is kind of a course, it's a specialty course, so it is harder to kind of use the knowledge that you've already built in nursing school for this course because it's kind of like a game of its own. Your assessments are different, the things you do are different, the medications you're giving are different. So it's kind of like you're almost having to relearn different skills to use in this course set. So what we're going to use today is your test plan that you guys have online under your weekly course units. So I've taken that, and those are kind of just an outline of everything that you could possibly have on your exam. So we're going to go through that, and then I will kind of break everything down a little bit better for you to be able to understand, because I know sometimes reading it in the book, especially when it's something that you've never actually heard before or done before, is kind of harder to understand. And sometimes it's easier if you have somebody explain it a little bit better to you. So, when we have somebody who is newly pregnant, they've just found out they're pregnant, they're picking the facility they want to go to. There are a couple of different provider roles that they can choose from. So, you have family physicians, OBGYNs, and then certified nurse midwives. Your family physicians, these are people who can provide health care for your complete lifespan of medical education. They manage uncomplicated pregnancies. So they can do things like minor surgical procedures, they can do vaginal delivery. Some of them can perform C sections, most of them do not in real world. NCLEX world, they can, but real world, most of the time, they don't. Um, if for some reason the patient were to have a C section, most of the time they go ahead and transfer care on to the OBGYN. So your OBGYN, these are people who manage everyone. This is what they went to schools for. They're well versed in various complications for pregnancy. So these people provide care for pregnant women through all phases. So they may see them as a gynecological provider while they're trying to get pregnant. And then when they're pregnant, they'll um, see them during that lifespan of their pregnancy. And then they help deliver them, whether that be vaginal or C section. And then they'll also see them postpartum. So they can do everything. They also manage complicated patients. So they are about the only people that can manage complicated patients. And when I say complicated patients, I mean people who have severe preeclampsia that have turned into eclampsia. Maybe they're having seizure like activity from their preeclampsia. So anything that you can think of that's like super bad that makes your pregnancy complicated, your OBGYN is going to be the only person that's going to be able to manage that. Certified nurse midwives. A lot of people are using or choosing to use these days. These are people who can also provide preconception care. They can provide you prenatal care, maternity care, postpartum care. Now, the only difference between the OBGYNs and the midwives are your midwives cannot manage complicated patients. So they may have a patient from the time that they're doing preconception counseling all the way till they're pregnant to the end of their pregnancy. And let's say when they're 36 weeks pregnant, they develop severe preeclampsia. They are then going to have to transfer care to an OBGYN because they are not allowed to manage very high risk patients. Your nurse midwives can also not perform C sections. They will also have to transfer care to an OBGYN if that happens. So if you have a patient in the hospital, you've labored this patient for days now, and we're pushing, we're about to deliver, and then the baby just fails to descend. We don't have any baby coming down anymore. Then at that point, they are probably going to need a C section, and your midwife is going to have to transfer care to the OBGYN. So Just make sure you know those three types, the types of patients that they can see, and then go from there. So, does everybody have a good understanding of that? If I gave you like patient scenarios, do you think you'd be able to pick out who would be able to see what patient? Perfect. All right. Prenatal history collection. So this kind of encompasses a lot, right? So like there's a lot we have to know about our patient when we are first seeing them for the first time and they're pregnant. So one of the big things that first comes to mind is Nagel's rule, right? Everybody should have a pretty clear understanding how to do that. It's not super hard math. So you find out from your patient, hey, when was the first day of your last menstrual period? They'll tell you. You subtract 3 months from that first day of their last menstrual period, and then you add 7 days to that, and then that is going to give you your patient's estimated due date. We're not going to spend a lot of time on that because that is very simple and self explanatory. All right, so your initial prenatal exam, like I said, this is going to cover a lot. And a lot of patients will say, why do I have to do all this? This is important because a complete assessment of your overall health influences your pregnancy. So that's why we're checking labs. That's why we're checking measurements of your pelvis. That's why we're getting ultrasounds of your uterus and checking those measurements because a complete assessment of your overall health influences your pregnancy. Important to remember that. If we have somebody that has something going on, we want to make sure that we get that taken care of so that they have a uncomplicated pregnancy. So for your complete exam, your provider may do a pelvic exam. So everybody kind of knows what that is. You're going to be placed in lithotomy position. They're going to inspect the outside of the vagina, make sure they don't see any lesions or any discharge that's abnormal that's coming out. If they feel like they see something that may be considered an STI, they may do a swab and send that off just to make sure. And they may also do a PAP as well. Some providers may do a bimanual exam. A lot of people kind of spare on this and they don't typically really do that anymore, but sometimes they still will. So that's kind of where they're really filling up in their good. They're going to palpate your uterus, they're going to try to find your fundus, determine the size of that, the position of it, if you have any tenderness, is it firm, is it soft? And then another major point to remember is they're going to look at your pelvic bone structure. So, your pelvic bone structure is something that is super important, probably honestly one of the most important things for birthing process. You have a couple of different parts that are in that pelvic bone structure. One that is super important is called your ischial tuberosity. So, this is the smallest dimension of the pelvis. This is the point that it's like the baby's last point of coming out of that pelvic bone before it's really going to start actually being born. Your ischial tuberosity should be at least 10 centimeters. Why? Because we dilate to 10 centimeters, right? So if it's not 10 centimeters, then hey, we're going to have a problem. So if you are feeling inside of someone and you notice that their ischial tuberosity is a 6 or a 7, what do you think might happen during the birthing process?
The baby's probably going to get stuck and you may have to do a emergency C-section.
Perfect. Yeah. So if we are trying to fit something out of a 10 centimeter or that's supposed to be 10 centimeter hole and it's only 6 centimeters, we can't push that watermelon through there, right? Like it's just not going to happen. So if we don't start off good with that full 10 centimeters of an ischial tuberosity, tuberosity, then we're probably going to have a C-section because, like I said, you can't squeeze it through there. It's just not going to happen. So that's the super, super important one that you need to remember. You also have what's called an obstetric conjugate. This is the diameter that extends from your sacral promontory to the upper inner border of your symphysis pubis. It measures around 11 centimeters. It is important also because this is the first bony prominence that the baby has to go through in order to like make its way down to that ischial tuberosity. You also have what's called a diagonal. Diagonal conjugate. So this is the distance from the lower posterior border of the symphysis pubis to the sacral promontory. But like I said, ischial tuberosity, that's the one that you really need to pay attention to, because if it's not 10 centimeters, you're probably going to have a C-section. So, normal routine labs that you do during pregnancy, you want to do a CBC. So, this is going to determine the overall health of the patient. It's also going to determine if there's any sort of anemias going on, because those are things that we would need to start correcting early before delivery. You'll also do blood typing and RH sensitivity to identify the mom's blood type. So if she's A, AB, B, or O. And then also the RH status. So is she RH positive, or is she RH negative? Now, remember, if she's RH negative, she's going to have that RhoGAM shot during pregnancy. And then you guys will kind of learn about this a little bit, but once the baby's born, they'll also check the baby's blood type. And then if it is incompatible, mom will have to get a RhoGAM shot within 72 hours after delivery. Now, that is something that it does not matter if you have a baby full term, the baby is living, great. If it's still incompatible, mom still has to have the RhoGAM shot. It also is the case if mom has some sort of an abortion. So let's say that mom is pregnant and she's 26, 28 weeks, somewhere in there, and she starts having a miscarriage. So spontaneous abortion, goes to the hospital. She has the miscarriage. They will still test those fetal cells to see if mom and baby are compatible or incompatible. If they are not compatible, then mom will still have to have the RhoGAM shot within 72 hours of delivery. This helps not to really protect baby, but to protect mom and future pregnancies, okay? Because the body kind of sees those cells, if they're incompatible, like it is some sort of a host or something that is like invading the cells, and they're trying to protect the mom from it. So they are trying to like destroy any foreign cells that come in mom's body. So subsequent pregnancies, if they have those cells left over from the last pregnancy, they're thinking, okay, here's those cells again. We need to destroy them. So that's what causes the moms to have early miscarriages if they do not get those RhoGAM shots. So, moral of the story, um, if mom has healthy delivery and they're incompatible, she still has to get the RhoGAM shot within 72 hours. If she has a miscarriage at any point in time, incompatible, still has to get the RhoGAM shot. Everybody good with that? Yes.
I was going to ask real quick. So, is there a post-delivery RhoGAM shot for the baby?
No. So the mom is the only one
Yeah.
that gets that.
Okay. Okay. Thank you.
Yeah, because it's not really about protecting the baby. The baby, this kind of sounds bad. The baby is almost the one that's kind of like causing it, right? So, like I said, like the baby's cells and the baby's blood could mix with the mom's, and then your body is seeing that as in, hey, that's not mine. What's going on? Why is something coming into my space, trying to invade my space? Is this something that's going to harm me? So it tries to kind of like, quote, kill all that off. um, and that's why, like, if it mixes for future pregnancies, it will say, hey, here's those cells again. What are those? We need to kill them. And then that will cause a miscarriage early on. So you're getting that shot to protect you as the mom and future pregnancies to be able to hold. So it really doesn't have anything to do with the baby itself.
Thank you so much for clarifying.
Uh-huh. All right. So rubella and varicella titer is also another lab that we will do. The rubella titer is to determine whether the patient has immunity or will need the vaccine after giving birth. You're also going to have patients all the time that say, why do I need to have this? I've already had the vaccine before. Or why am I getting tested for this? I probably have immunity. You really want to educate your patients and say that this is because even though you may be vaccinated, you may not have immunity, especially when you become pregnant. So it's always super important that we check a varicella and a rubella titer, um, because you may not have immunity, even if you think you do. Okay. Important to remember. You're also going to check for hepatitis B and C. That's just obviously to make sure if we have that or we don't. Like I said, they may do an STI screening if they think that that's necessary. Urinalysis. You're going to get those probably 12 million times in your pregnancy. Definitely starting out. Some places do them every single visit. Some places do it right whenever you start out with your first visit, and then they may do it around like 20 weeks. And then like right before you're going in to deliver, and then you'll have one in the hospital, obviously. These are used to detect bacteria, ketones, glucose, and protein in the urine. So let's say that you have someone and they have given you a urine specimen and you are looking at your chart and it says that you have a lot of nitrites in there. What would you guys think is happening?
She has a UTI.
Yep, perfect. And that is super important to know that because you need to catch that. So UTIs can be kind of like a big thing for anybody, right? Like it can obviously cause fever. It can end up being pyelonephritis. It can do scarring of your ureter tubes, big things. Pregnant women, it kind of is like your downfall almost. So if you have a UTI, it's going to irritate your uterus. It can cause you to start cramping. It can cause you to start having contractions. So very super important that we know nitrites mean you have a UTI. So if we see nitrites, we know that the patient has a UTI, and we would want to get that treated so that we don't have any further complications. Now, other end of the spectrum, if we've seen someone who has a lot of glucose in their urine, so let's say they have like 1, 2, 3 plus glucose in their urine, then what would we think that that means?
I'm gonna say gestational diabetes.
It could lead to that, yeah. So as nurses, we're not super allowed to diagnose things like that. So if we see someone who is having a lot of glucose in their urine, that's something that we would report to the provider, correct? So they're not metabolizing glucose well somewhere. So something is going on, which you are right. It could be leading to gestational diabetes. So any sort of glucose in the urine, they're not metabolizing it correctly, and then we would also worry about that. Let's see, your Group B strep test. So this is done anywhere from 35 to 7 weeks. It is a like cotton tip applicator. And what they'll do is kind of swab the inside of the vagina and then they'll like pull it all the way down to the rectum. Some providers just kind of rub it on the outside of the rectum. Some go inside of it a little bit. Just kind of depends on who you're getting. Hopefully, you're one of the ones that get the ones that rub on the outside, not go all the way on the inside. But done between 35 to 37 weeks. It is a bacteria that lives in the vagina and the rectum. You are more than likely going to have this and not have any symptoms because it usually doesn't cause any symptoms. It's just kind of like a bacteria that either you test positive for or you don't. This is something that is super crucial, super important to know about your patient. So if you end up becoming a labor and delivery nurse, you always, always, always want to look at that patient's GBS status to see if they are positive or negative. This is because this bacteria can be passed to the baby through birth and it can cause all kinds of health problems for the baby. It can cause them to become septic, it can cause them to be blind. Very big bad infection if we do not treat it. So, if your patient is positive, then they will have to get antibiotics during delivery. You don't really have to know a whole lot about the antibiotics, but just for like your knowledge sake, um, when the patient comes in, they do not have to have them right away. Once they start active labor, they will get some sort of antibiotic. Most of the time, it's penicillin, usually every 4 to 6 hours, right up until they deliver. This helps to eradicate the bacteria, make sure we don't pass it to the baby, and everything's good. So, as long as we treat it, it's fine. But just know GBS is a swab we do at 35 to 37 weeks. Um, to make sure that we are either positive or negative, and then if we're positive, we treat it. All right. So that is kind of like all of the labs. Is everybody okay with that before we move to the screening and the diagnostic tests? Perfect. All right. So obviously we're going to do an HCG test, right? Because that's like, hey, we're definitely pregnant or we're not. Um, that's a big one. And then we will also do an ultrasound because if we see baby on the screen, we're definitely pregnant, right? And then I'm trying to see which ones are on here for you. All right, your quad screening. So this is something that is performed on the mom's serum between 15 and 20 weeks to detect specific serum markers. Now, this is not done on every single person. If we need to do it, we're going to do it. If not, we're not going to do it. So this kind of tests for neural tube defects. It can indicate Down syndrome, trisomy 18. And there are a couple of different things that we look at on this quad screening, and their levels are significant. There's really no way to tell you to remember this other than you just have to sit down and tell yourself it a million times to remember it. So if your HCG is super, super high, then that can indicate Down syndrome. It does not mean that you are absolutely going to have a child with Down syndrome, but it is possible if your levels are really high. So, very high HCG could indicate Down syndrome on a quad screen. Unconjugated estriol, if the levels are low, could indicate Down syndrome. Inhibin A, if the levels are high, will indicate Down syndrome. So, HCG, inhibin A, if they are high, could indicate Down syndrome. Unconjugated estriol, if they are low, can indicate Down syndrome. Everybody okay with that? Those are something that you are going to have to know. So, my suggestion would be memorize the two that does not that are the same. So HCG and inhibin A are high, and then you only have one left, and it's low. Okay. All right. Amniocentesis. So this is something that can be performed to diagnose Down syndrome. It can be used to diagnose cystic fibrosis, spina bifida, and other sorts of genetic disorders. This is something they definitely do not do all the time because it does have risks, and they can be pretty significant risks. It is an ultrasound guided thin needle that they actually poke into the mom's belly, and they use it to remove amniotic fluid from the amniotic sac that surrounds the baby. So that sounds pretty dangerous, right? We're taking a needle and poking something that we're supposed to be protecting and trying to not pop our amniotic sac and all that. Yeah, very dangerous. So complications that we have to watch for this are spontaneous abortion, infection, because we have a needle going into a surface, right? So anytime we have any sort of needle or anything trauma into a surface, we always have to worry about infection. And then needle injury to the fetus. So they may actually hit the baby while they do this. Leaking of amniotic fluid is also another one. So that can be from the site, or if they rupture the amniotic sac, then you may have it also from the vagina as well. So any sort of leaking of amniotic fluid. With that, definitely just make sure that you know the complications, okay? So like if you had like a list of complications, be able to pick out the ones that are on there. So spontaneous abortion, infection, needle injury to the fetus, and leakage of amniotic fluid. All right, your prenatal visits, you're going to go monthly for the first 28 weeks. And then every 2 weeks until you're 36 weeks. And then once you hit 36 weeks, you're going to go every week after that. That's just because you're very close to delivery. They want to make sure nothing has changed and that baby still looks good and everything is still great. So monthly, first 28 weeks, every 2 weeks until you're 36 weeks. And then once you're 36 weeks, you're going to go weekly until you deliver. All right. So, care during your prenatal visits. It's very important for the woman to have regular care during her prenatal visits because, like we said, your overall health is going to impact your pregnancy, right? So, if you have some sort of complication, we want to make sure that we are catching it early. We are implementing your appropriate care to treat this so that you have a uncomplicated pregnancy, hopefully an uncomplicated delivery, and a healthy baby. Make sure with each visit you are addressing your patient's concerns. You are asking them if they have any concerns, any symptoms that bother them, and also make sure you're doing a psychological eval on your patient. So, first off, the thing that we think about with the biggest is PTSD. So, let's think about these women who have had maybe they've been raped or something. When you're pregnant, you're very exposed to a lot of people. You're constantly like having to show your belly, you're having to show your perineum area, you're having to get maybe transvaginal ultrasounds during your labor and delivery process. You're getting checks. I mean, you're pretty exposed out to the open for everybody that's in there, right? For someone who's been raped, this can be very traumatic. So if you have seen on your patient's chart or they have told you that they have been a victim of rape, you always want to make sure that you're being very sensitive towards your patient and maybe you have to take a little bit more time with these patients. So instead of immediately going in and like touching on their belly to try to palpate the baby or raising their shirt up to try to get fetal heart tones, you may go in, introduce yourself, talk to them for a second, which is what you should be doing anyways. But you might say, I need to feel the position of the baby. Is that okay? And they'll say, yes. And then you'll say, okay, you're going to feel my hands touch on your belly. So you're explaining to them what you're doing instead of just jumping and putting your hands on them to kind of create more of that traumatic situation for them again. That may be replaying in their head. Same thing with the Doppler. This is my Doppler. I need to listen to the baby's heart tones. You're going to have a little bit of gel on there. I'm just going to raise your shirt up. We'll put that on there, and then I'm going to hear the baby. Is that okay? Now, whenever you're in the labor and delivery setting, kind of take it more slower with your patient. Say, okay, let's get you hooked up to the monitors. Same situation. If you need to do a check, you need to say, we really need to do this check. This kind of lets us know how far dilated you are. It lets us know what position that your baby's in, kind of gives us more of an insight to how our labor process may go. Is that okay? They can deny it, and that is okay as well. They have their own patient rights. If they say okay, though, you need to make sure you say, okay, I'm just going to put a glove on my hand. We're also going to have some gel on here. I'm going to talk you through this. Once they kind of get in their position with their legs open and butterfly to the side, you can say, okay, you're going to feel me touch now. It may feel a little bit cold. You may have a little bit of pressure. And then just make sure you kind of like slowly check your patient. You're not like yeeting your fingers in there, right? Okay. Be very careful with how you're treating these patients. And just make sure you're always asking permission before you touch them. Don't rush them, and then explain everything. Even if you feel like you're being silly and that may be something they already know, just explain it because I promise it's going to make them feel better in the end. Everybody good with that? Okay. You're obviously going to weigh your patient because we have to monitor weight, right? During the, sorry, I think one of my kids just walked out in there. You have to monitor the weight during pregnancy to make sure you're gaining appropriate amount of weight. You're going to monitor vital signs because we want to make sure those stay within normal limits. We don't want any blood pressures creeping up that may lead us to think we're getting preeclampsia or full-on eclampsia. They'll measure your fundal height. So the fundal height is from the top of the pubic bone to the top of the uterus. So when you're feeling for that, you're going to feel down at the bottom, and everybody knows what your pubic bone feels like. So it's kind of like that little hard surface. And then your fundus almost feels like a little round shelf. You don't have to push super hard to feel on it, but if you kind of like make a concaved C with your hand and then use like the outer portion of your hand, you're going to be able to feel that really well. just feels like a little shelf. You'll feel like hollow area, and then you'll find the little shelf. So that's how you measure the fundus height. The fundus is supposed to reach the umbilicus at 20 weeks, and it should measure 20 centimeters. Another important screening that we would do with our patients is domestic violence screening. This happens at every routine prenatal appointment. It also will happen whenever your patient checks into the hospital to have their baby. Intimate partner violence is something that is very big. It is on the rise. And for some reason, these poor pregnant patients are the ones who are always in the domestic violence situations. So your screening questions you'll ask: do you feel safe at home? Do you and your partner fight? If they answer yes, does the fighting become physical? And then, have you ever been hit or hurt by your partner? Now, this is something that you also have to play smart. If you have someone who you think may be in a domestic violence situation with their partner, if their partner is attending every single prenatal visit with them, they're probably not going to tell you the truth, right? They're probably going to say, yes, I feel safe. No, we don't fight. No, it doesn't become physical. No, he's never hurt me. But you can kind of see like the partner may be answering the questions, or when you ask a patient the question, they'll look at the partner, or they may even have visible signs of violence, the bruising, anything like that. So, what you may do is say, okay, we need to get a quick urinalysis for you. If you'll follow me, I can show you where the bathroom is and get you your supplies. That can kind of be a way that the partner may be able to stay in the room. You're taking the patient out of the room, and then that may be the time that you say, hey, do you feel safe at home? What do you feel like you're in a safe environment? Has your partner ever hit or hurt you? And they may tell you the truth at that point because they are away from their partner. Don't ever push the issue. If they say no, don't ask them again. But if you do think that it is something that needs to be reported, then that is something that you are mandated to report. Warning signs of domestic violence: if your patient is late or absent to appointments. Now, that doesn't mean that they've missed an appointment and they've been to every single one. That means that they're showing up 15, 20, 30 minutes late to appointments, or they're just not showing up at all. And that's like consecutively. They may have an injury to the face, the head, the neck, chest, or abdomen. Any sort of vaginal bleeding, always think that kind of comes to mind. It doesn't necessarily mean it's the case, because we also know that there's other things that can go on prenatally that can cause vaginal bleeding, but keep that in the back of the mind. Any sort of anxiety, depression, or self-harm, signs of alcohol or substance abuse. Like I said, if the partner demands to attend all of the visits or answers for your patient. And then this is something that you must document and you must report. So, everybody good on that? Hang on, it looks like someone's trying to join. Okay. Let's see. All right, weight gain. So when we're talking to our patient about diet, we need to tell her that she needs to avoid empty calories like sugary items, fried foods, soft drinks, desserts, all the stuff that you probably crave when you're pregnant. Not necessarily the best option for dietary. We also need to tell her that it is important for her to take folic acid. So this is a vitamin, folic acid, folate, they're both the same thing, that helps to prevent neural tube defects in a fetus. So folic acid helps to prevent neural tube defects in a fetus. Now, there are natural types of folic acid, and then there's the actual pill that they take as well. They do need to continue to take the pill, but they can also do dietary sources. So these are things like cereals that are like whole grain, any sort of beans, spinach, kale, broccoli, asparagus, And the recommended allowance of folic acid is 600 micrograms per day. So, folic acid or folate, whichever one you want to call it, helps prevent neural tube defects. For your weight gain, if you have a BMI less than 18.5, your patient is going to be considered underweight and she should gain 28 to 40 pounds. If you have a BMI between 18.5 and 24.9, this is considered normal weight. So they're starting out on track and they should only gain 25 to 30 pounds. If they have a BMI between 25 and 29.9, then they're considered overweight and they should only gain 15 to 25 pounds. If they have a BMI greater than 30, then they are considered obese and they should only gain 11 to 20 pounds. So this may not seem like something that's super important to remember. And as nurses, it's not like crazy important for us to remember. It's more on the provider side, but you would report it to your provider. This is something that can kind of set the whole pregnancy for you. So if you are gaining too much weight, that can cause the baby to be what's called a macrosomic infant. So the baby can be very large. That can cause complications for the baby. It can also cause complications during birth. So it is really important to remember this chart and you will be tested on it. So I would make sure to write that down and just kind of study it. All right. Let me, if you bear with me for just a second, I'm going to try to pull up the book. On page 97, there is a table 7.1. I would definitely study that. So it's the different types of like medications and stuff for pregnancy. One that's really super important. One thing that's super important to remember is obviously teratogens, right? So teratogens are anything that can harm the baby, especially during the first trimester, but mainly the first couple of weeks. Teratogens can be anything like certain types of medications, anything like that. So, a common symptom for a pregnant woman to have when they are first pregnant is nasal stuffiness or congestion. And that is because you have so much estrogen and so much progesterone that are building up to support your pregnancy. It kind of causes like irritation to the nasal cavity. So if you had someone who had come into the provider's office and they say, hey, like I just feel like I really have a bad sinus infection and I just can't kick this. You might say, have you tried any sort of like non-pharmacological measures? And they may say no. You would tell them that they could use saline nasal spray because this is something that is safe. It is natural, right? It may help to loosen up the mucus in there to get it out and also maybe cause the nasal passages to not be as inflamed. And that's something that we can use that is not a medication that we're automatically throwing on board and causing teratogens to be exposed to your baby. Mariah, that's page 97 and it's box or table box, whatever, 7.1. So any sort of non-farm option that we can use, if we're not absolutely having to use a medicine, then that's what we would do. So that's why we would tell them, hey, let's try to use saline spray for your nose and your congestion versus introducing a medication that could be teratogenic to your baby. Everybody good on that? Perfect. All right. Hyperemesis. So this is something that is very severe. A lot of people have normal nausea, vomiting during pregnancy, can be throughout the whole pregnancy, can be normal, may not be something to worry about. These people who have hyperemesis are very, very, very sick. I had this with my first pregnancy, my daughter, and it was horrible. So this is severe morning sickness that persists past 20 weeks. This is not I'm throwing up once or twice in the morning and then maybe once at lunch and then once before I go to bed. This is like I'm puking 10 times in an hour. And when I do, it's a pretty significant amount. So very, very persistent vomiting that goes past 20 weeks. where you're out of the first trimester, quote, nausea stage. This is something that can cause dehydration because you're throwing up a lot, electrolyte imbalances because you're losing a lot of fluid, right? And you may not be able to replenish them back. It can cause acid base imbalances, and then also nutritional deficiencies. If you're not able to eat because you're throwing everything up, you're not getting nutrients. Your baby is taking everything it needs from you, and it may not be getting much, and you're getting left with nothing because baby's taking what it needs from you, right? It can even cause death if it persists to the point of you just absolutely are nutritionally deficient. Risk factors. So this is kind of like a wide variety. There's not too many known risk factors, but there are some. So if you have a super high HCG within like the first couple weeks of your pregnancy, sometimes that has been pinpointed to people who have had hyperemesis. Um, and then also if you've had like a previous intolerance to oral contraceptives. So, younger years, or maybe right before you got pregnant, you tried to take birth control, could not do it, made you sick, you vomited, had a lot of nausea. That could possibly be a risk factor for hyperemesis as well. So, if you have someone who does have hyperemesis, this can cause preterm labor, it can lead to preeclampsia, placental abruption, dehydration. And then for the fetus, it can cause poor placental perfusion. So we know our placenta is our lifeline for our baby, right? If we're having poor placental perfusion, then the baby's probably not getting adequately oxygenated like it's supposed to. This can cause fetal growth issues. They can become compromised. So the baby may be SGA or small for gestational age. So this is something that can cause a lot of problems during pregnancy. Your signs and symptoms with this: vomiting, like I said, a lot during the day, so multiple times throughout the whole day, poor appetite. A big one is weight loss greater than 5% of your pre pregnancy weight. So, whatever you're starting out pre pregnancy weight, if you're having a 5% weight loss during the pregnancy, then that would be a classification. Dehydration, dry mouth and skin, right? Because we have dehydration. Poor skin turgor, also have dehydration. Concentrated urine, we're not drinking a lot, we're not having a lot moving in and out, so our body's trying to hold on to that, which makes it more concentrated. Decreased urine output, we don't have a lot to pee out if we're not taking a lot in, right? Elevated heart rate, which is also a sign of dehydration, so tachycardia. And then you can also become alkalotic from the hydrochloric acid. So, medical care, B6 is a natural supplement that you can take during the day. You can also take it during the night. And then doxalamine, you can take that. Ginger is a natural alternative that you can do. They make like ginger pops, ginger teas, things like that. And then if you've tried all of those, the nausea and vomiting is severe, then they may move on to the bigger things. So metoclopramide or Reglan, promethazine, which is Finagrin, ondansetron, so Zofran. They try not to give you Zofran during your first trimester because it's not super, super safe. If you have to absolutely have it and it's like, oh, this is the only thing that's going to make you better, or we're heading down the wrong track, they'll give it to you. Most of the time, they try to start out with like the natural things. So the ginger, the B6, they may sometimes give you Unisum as well in line with the B6 to help out. All right. Does everybody feel okay about hyperemesis? Okay. Let me find our next topic here. Oh, this is a big one. Okay, you will need to know this. Patient teaching for hyperemesis. So we want to tell these patients to eat small, frequent meals. They want to kind of be like a little bird and snack all day, right? That way we're constantly getting something in, but we're not overeating to where we're already like engorging ourselves and making us more nauseated. Avoid spicy and fatty foods. Identify any foods that may have a like very pungent odor, so that it doesn't trigger nausea. And then making sure that you're maintaining your fluid intake by just sipping throughout the day. So you don't have to sit and like chug something to try to keep it down. That's going to probably make you throw up. Just make sure that they have some sort of fluid by them all day and they're just sipping on it. Monitor for signs of dehydration. So you should teach the patient, um, you know, a decrease in urination, an increase in your heart rate. Maybe you're feeling dizzy. Maybe you have a dry mouth, you have poor skin turgor. Those would be signs you would watch for dehydration. And then to notify the healthcare provider if she has any of these symptoms. So, any dark urine, blood in their vomit, abdominal pain. So, another thing we have to worry about is if we get very dehydrated, our uterus is a big muscle. So, what happens to muscles when we get dehydrated, right? They start cramping. That's going to happen with your uterus as well. You're going to start having contractions and you're going to start cramping, which, hey, can throw you into preterm labor, which is a side effect of hyperemesis, right? Inability to keep food down for 24 hours. And then, yeah. So that's the last with hyperemesis. Everybody okay with that? Perfect. All right. Pica, pica, however you want to say it. That is a nutritional deficiency that is common during pregnancy. So it is an eating disorder that can occur, and they eat non-nutritive foods and non-food substances. So it's like a really bad craving that they have, and it's for stuff that's really weird. Like they may want to eat rice or clay, or not rice, but ice or clay, or dirt or soil, anything like that. Just kind of weird stuff. This is something that we don't really know why it happens. Most of the time, it kind of points to like a nutritional deficiency that they're having. So, some sort of something they are deficient in is causing them to have all of these cravings. If this happens, we want to encourage her to eat a balanced diet. We can recommend that she selects some sort of a person, whether it be a friend, a neighbor, family member, spouse, anybody who she can talk to about and just tell them about the situation. And that way, this person can kind of monitor and assist her to where she won't be eating harmful substances. All right. So spontaneous abortion, this is something also you'll have to know. There are a couple of different types. So threatened abortion, these are diagnosed when vaginal bleeding occurs. It can be possibly accompanied by abdominal cramping, and the woman may or may not lose the fetus. So the way I think about this is the baby, this is kind of weird, but sometimes I had to do stuff like this in nursing school to remember it. And I've always taught it like this and it helps people remember. So the baby is threatening you with a threatened abortion that it may come out. So you may or may not lose the fetus. An inevitable abortion. So this happens whenever the cervix dilates, the amniotic sac ruptures, the fetus and the placenta are expelled unless the healthcare provider intervenes. So, inevitable. We are inevitably dilating. Our membranes have ruptured. When all that happens, birth is inevitable. Inevitable abortion. Incomplete. So, this is whenever some of the uterine contents of pregnancy are expelled, but not all of them. The retention of products of conception leads to uterine bleeding and cramping. So, incomplete, you didn't finish it, right? So, some of the contents have came out, but not all of it. Incomplete. Complete abortion is just what it says. All of the uterine contents are expelled. When this occurs, you'll have uterine cramping and bleeding stop without intervention. So, it's complete. Everything's done. Everything has came out. Missed abortions, also just what it sounds like. You missed it. So this is whenever the baby passes away during the first half of pregnancy, but you don't know that it's passed away. You've not expelled it. You're still carrying it. And you will carry it until spontaneous abortion occurs or until the healthcare provider catches it on your next ultrasound, and you may have to go in to do a D&C for the provider to remove all of the products of conception out of the uterus. Do we need to go over those again, or everybody okay? Because those, you will have to know those.
Honestly, I think you should repeat it one more time if you don't mind.
Sure. So, threatened abortion, like I said, it's kind of like you're being threatened. You will have vaginal bleeding by abdominal cramping, and you may or may not lose the fetus. So, I'm threatening you that you may lose me, you may not. Inevitable abortion, this is when the cervix dilates, the amniotic membranes rupture, and the fetus and placenta are expelled unless the healthcare provider intervenes. So, inevitable, it's inevitably going to come out, and you're going to have the baby unless the healthcare provider does something to stop it. Incomplete abortion, some of the uterine contents and products of conception are expelled, but not all of them. So it's incomplete, right? Some of them are out, some of them are not. Complete abortion, this is when all of the uterine contents are expelled. Everything's out, right? Complete. We're done. Complete. Missed abortion, we've missed it. So we may not necessarily know that we've had an abortion. The baby's passed away. This happens during your first half of pregnancy. The fetus is not expelled. You will still carry the baby and remain pregnant until your body chooses to make you go into labor, or unless the provider makes you go into labor, or you have a D&C to remove those products. So missed, we don't know that it's happened until we either have an ultrasound or our body sends us into labor.
Thank you.
Mm-hmm. So, some signs and symptoms of spontaneous abortion in general. You can have lower abdominal cramping, vaginal bleeding. These can also occur early in pregnancy as well. Those symptoms can. That's why it's important that we do our physical exams and ultrasound, HCG testing before treatment begins, so we can make sure exactly what is going on. So if you have someone who has had either a planned abortion, a spontaneous abortion, you need to teach them these warning signs if they've had some sort of a D&C. The warning signs that should be reported to the healthcare provider are heavy bright red bleeding, foul smelling discharge, fever, pelvic pain. So any of those. Basically anything that is bleeding or super bad, you would report to your healthcare provider. All right. Ectopic pregnancy. So this is something that the cells that are trying to become baby implant outside of the uterus. So they're not inside the uterus. They can implant on like a side of the fallopian tube or just anywhere that's outside of the uterus. So signs and symptoms of ectopic pregnancy include vaginal bleeding and abdominal pain. And then if the fallopian tube ruptures, so some people may not even know they have an ectopic pregnancy because they have normal symptoms. The bad part about ectopic pregnancies are you usually find out in a blaze of fury. So most of the time the fallopian tubes have ruptured. That's when you're going to have your bad symptoms. That's when you're going to have these people rush into the ER because they have severe abdominal pain, shoulder or neck pain, because that fallopian tube has ruptured. So you're bleeding freely into your abdomen and it's pushing everything up and it's causing that shoulder and neck pain. So severe abdominal pain, severe neck or shoulder pain. They may be weak, dizzy. They may have a decreased blood pressure because they're hemorrhaging, and they may have an increased heart rate because they're hemorrhaging. So everybody good on those signs and symptoms, because once again, you will have to know those. Okay. right, so let's say now that we have talked about ectopic pregnancy, we have a placental abruption. So, placental abruption is premature separation of the placenta from the wall of the uterus. So, when that separates, you have bleeding between the wall of the uterus and the placenta. This can be a partial separation or a complete separation. Either way, your patient is at risk for severe hemorrhaging with a placental abruption. These are things that are super, super, super bad. So risk factors for a placenta abruption is abdominal trauma. So whether that be our domestic violence situation that we talked about a while back, maybe it's a car accident, maybe somebody fell trying to walk down a hill. Any sort of abdominal trauma can cause placental abruption. Alcohol abuse, cigarette smoking, multiple pregnancies. So if you have someone who's pregnant with twins, triplets, anything like that, it can cause placental abruption. Short umbilical cord, advanced maternal age, if they have had a previous history of placental abruption, or sudden decompression of the uterus, or prolonged rupture of the membranes. So, the number one cause of placental abruption is hypertension. So, this is because hypertension puts lots of stress on our arteries and vessels, correct? If we have hypertension over time, already complicated, and then we add pregnancy on top of that, it kind of is like a ticking time bomb. Those get really big and inflamed. We have even higher hypertension that can cause the abruption of the arteries or the vessels and cause it to separate from the placental wall. So, hypertension is the number one cause of placental abruption. All right, placenta previa. So, this is where you have a certain spot that your placenta is supposed to implant with each pregnancy to be considered, quote, normal. Placenta previa, your placenta implants not where it's supposed to. So it may implant near the opening of the cervix. So if you think about it and your placenta is already right near the opening of the cervix, we're kind of worried about that, right? This can become detached. So your placenta can become detached and it can put the baby at risk. Risk factors for this are a previous C-section, previous placenta previa, any sort of uterine scarring from endometriosis, previous spontaneous abortion, non-white ethnicity. So those who are non-white have a higher chance just because of like genetics and genes, and then smoking. So signs and symptoms of this can be painless bright red bleeding. This is something, if you did not take anything else out of this class, please take this. If you have someone who comes in and they're complaining of pain and they're pouring the blood from their vagina, please, please, please do not stick your hands or any sort of instruments inside of this person, period, because they could have placenta previa. And if you stick your hands in there, you could go ahead and detach their placenta, and then you are booking a trip to the OR and it's going to be real bad. So please, if you have any sort of heavy pouring blood out of the vagina, do not stick anything in there, please. If that happens, you need to immediately call your provider. Immediately. They will handle the rest. They will call the OR team. They will get an ultrasound to confirm as you're on the way down to the OR. And you will need to have a C-section if you have a complete placenta previa because it is an emergency. Everybody good on that? Great. All right, preeclampsia. So this is hypertension and proteinuria. So you have protein in your urine after 20 weeks of gestation. So that's important. The diagnostic period is after 20 weeks of gestation. When you have preeclampsia, you also have edema that is accompanied by Now, pregnancy, you also have normal edema, right? Because we're putting on some extra weight, some water weight, placenta weight, baby weight. This edema has to be accompanied by hypertension, proteinuria, and after 20 weeks of gestation. Risk factors for this can be prima gravida, if you're advanced maternal age, so more than 35 years old. If you have a previous history of preeclampsia, chronic hypertension, multiple gestations, obesity, or if you're someone who has a frequent UTI. Okay. All right. So that was all from the study sheet. Let me take a look at this page right here and make sure that we've covered everything that you'll need to know. And if not, we'll go back over it. All right. So we talked about our providers we would use. We talked about screening for partner violence, so you know your questions that you would ask, and we talked about how you need to make sure you ask those, whether it be trying to take your patient to get a urine specimen, and anytime you're asking any sort of questions like that, you want to make sure you say, tell me about your home life, tell me about this. Ask those open-ended questions so that they are able to elaborate on the situation to you. We talked about the ischial tuberosity must be 10 centimeters. If it's not, then our client's probably going to need to have a C-section. We talked about those lab tests. So they'll need a CBC, they need a varicella, they need a rubella, your blood type and screening, all those things. So just know what lab tests you need to do during pregnancy. And then remember with like the rubella and the varicella, we said that they may ask why they have to have these because they've already had the vaccines before and they're sure that they're good. But you just say, hey, we don't know. Even though you may be vaccinated, you may not have full immunity. That can harm your baby. The quad screening. So remember we talked about that. Those 2 levels that were high and then the 1 level that was low, that could indicate Down syndrome. We talked about the complications for an amniocentesis, so make sure that you're looking back over those. The scheduling of your prenatal visits, so how frequent you should go. Teratogens, like I said, about medicines, if we can do any sort of non-pharmacological options, whether that be nasal spray or maybe a nasal lavage or something like that, if they have to try to get rid of nasal congestion. Oh, I'm sure you guys know this, but do you guys know what oliguria, nocturia, dysuria, all that is? Do you guys know those terms or no?
Does nocturia, does that refer to like urination at night?
Yes. So the way I remember is nocturia starts with an N, night starts with an N. Nocturia, you're waking up at night to go pee a lot. Oliguria, that just means a small amount of urine. Dysuria is painful urination. And then anuria is whenever you have no urine. Oh, okay. Here's one we did not talk about. So hygiene during pregnancy. Obviously we want our pregnant women to stay clean, right? So it's okay that they take baths. It's okay that they wash down there. We don't want them sticking anything up in the vagina, like no soaps or anything up inside their vagina to try to wash around in there because you'd be surprised some people do that. It's okay that they take baths as long as their amniotic sac is intact. So if their water has not broken, they can take a bath, and that is fine. And the only reason that we say after your water breaks, it's typically not the best idea to take a bath is because that is an inlet for infection. When your amniotic sac has ruptured, everything is going straight up in there to the baby. So baths, you're kind of sitting in your own filth, right? Your own bacteria. So it could go up in there and cause some sort of infection. And then when you're pregnant, obviously you have to avoid hot tubs, jacuzzis, saunas, things like that. Did you guys know that? That was in your chapter, I'm sure. Okay. Make sure you look at the weight gain. So, how much you should gain based off of what your BMI is. That group B strep, remember that's done between 35 and 37 weeks. It's that swab to where we see if they're positive or negative for the bacteria. If they're negative, we don't worry about it. If they're positive, they have to be treated during labor to make sure it's not passed to the baby. If somebody has pica, remember that they are having some sort of nutritional deficiency. So we want to encourage that they have a balanced diet. They may have that support person that they tell that to so they can make sure that they do not eat harmful substances. With hyperemesis, remember we told them to sit frequently throughout the day. If they see blood in their vomit, they need to call the doctor, avoid spicy and fatty foods, and that they need to eat small, frequent meals, not large meals. Look over the abortions again. Ectopic pregnancy we talked about. Remember that starts with pain, vaginal bleeding. They can have shoulder pain and neck pain as well. With ROGAM, remember we talked about that's something that the mom needs if they are negative blood type. So they'll get that during pregnancy. And then if they're incompatible with the baby, they will get it within 72 hours after delivery. And that means if they've had a live birth or they've had an abortion, they still have to have it if they're incompatible. Look over the risk factors for placental abruption. So we talked about, remember which was the number one cause for placental abruption? Do you guys remember?
Hypertension.
Mm-hmm. And then your risk factors for preeclampsia. Yeah, that should be about it. How do you guys feel about that? Do you feel like it went okay? Like it helped a little bit better?
Oh yeah, I think it really helped a lot.
Okay, good. I really,
Very beneficial. Thank you so much. We appreciate you.
of course, anytime if you guys want to keep doing these, we'll have to do them probably every Saturday. Because it's about the only time that I can do them. I have kind of a busier schedule. But I did this all the time whenever I actually taught live lectures and taught in person, and it helped a lot with my students. So I kind of have missed like actually teaching because I feel like it's a lot harder to learn sometimes off of AI. Of course, yeah. All right, yeah. So if you guys don't have any other questions, that's all I have. Just make sure if you do have any questions, shoot me an email. I'm probably going to be out the rest of the day, but I'll try to look at them as soon as I can. And yeah, good luck on your exams. And I'll post another link for next Saturday for